All right, behavioral support strategies with restrictive measures. So we have a new rule, everybody. We are effective 10/1/22. So this training, we're going to go through the requirements, but we're also going to point out what changed and what didn't. We have a lot of new people who are going to be implementing this rule, so we wanted to make sure that we were capturing both. So what does the behavioral support rule do? It limits the use of restrictive measures. This should look familiar to those of you who implemented the last rule back in 2015. It applies to all DD service providers across all settings: intermediate care facilities, developmental centers, supported living, waiver providers, all DD service providers. It also requires strategies to be interwoven into one single plan. And I have to say, State of Ohio, you guys have been doing a really great job with that. When are restrictive measures included? So you can only use a restrictive measure when there is a direct and serious risk of harm. You also can use a restrictive measure when there's likelihood of legal sanction. I'm just gonna keep moving. Risk of harm, again, means that there's a direct and serious risk of physical harm to self or others. I know that, the last time we lifted a new rule, this was really challenging for all of us, but we have improved so much. So with that, direct and serious risk of physical harm to self or others, the person has to be capable of causing the physical harm. So we can't say, well, he might do this. No, is he capable of hurting? And is the person hurting? Also, it must be causing physical harm or very likely to begin causing physical harm to self and others. Heidi, do you have anything you want to add?
I don't. There's no change to the way we're really looking at these. So I think you'll hear more about the changes upcoming. But if you're ever not sure, right, does risk of harm really exist? Feel free to reach out to us or join the workshop.
Likelihood of legal sanction. So what does this mean? This hasn't changed either. So if the person's actions are leading to possible eviction, arrest, or incarceration, then we can implement a restrictive measure. Now, I will say with eviction, say a person has a job and they have a new boyfriend and they're starting, they've decided that they want to help out their boyfriend and they're giving them checks, their paychecks. Now that could be, a little alarming for budgeting, and if you're giving your paycheck over to someone else. But it just depends on how much is that paycheck. If it's only $10, giving the boyfriend that $10 check isn't going to impact that person's ability to pay their rent. So, the likelihood of legal sanction with eviction in that situation, I don't think that exists there. However, if somebody has a paycheck that's much larger and more substantial, and if they gave that paycheck over to the boyfriend, then, then we would have an issue with possible eviction, and we would just have to talk with the person and work it through. Prohibited measures. We have a few changes that we will get into. None of the prohibited measures on this slide are new. So we have prone restraint. There's been a lot of work around prone restraint in the state of Ohio. We have health and safety alerts. These are the never evers. We never want to put somebody on their stomach face down during a restraint. Also, making sure that any manual or mechanical restraint doesn't impede a person's ability to breathe, or it's medically contraindicated or causes pain or harm to the person. So these are prohibited measures. We never ever would we do these actions to somebody in our care. Also,
yeah, Heather. No, I was just going to say that last one is my very favorite one.
Yes.
Right? Never should we disable somebody's communication device.
Yes, it's one of my favorites too, Heidi. And I was kind of holding it out kind of special because I've been around for a long time and we used to see that as a common practice. And so it's a really good thing when people have the ability to have voice and choice and they're able to speak up. So this is definitely a prohibitive measure. You do not want to disable a person's communication device.
Yes, I have to add real quick. I was talking with somebody last week who has a child that does not communicate with words, and he was having he was struggling at the moment, and he kept playing a video, and she might be on here. He kept playing a video that said, I'm feeling a little nervous. I'm feeling a little nervous, right? And right, that broke my heart. I thought, oh, you poor mama, that poor baby, right? But let's imagine that somebody was playing a different video that was not so nice or not so kind and was saying, cuss words. Still can't take the batteries out, right?
Thanks, Heidi. You'll notice this first bullet, denial of breakfast, lunch, dinner, snacks, or beverages. This is different in this rule. We've included examples such as Prader-Willi syndrome and polydipsia. We've done a lot of work around Prader-Willi in the state of Ohio. So if you're new to this work and you need some support, please know that we have a lot of resources for you. So this is different in this rule that goes in effect 10/1. That does look different for somebody with Prader-Willi for sure. And again, these are only examples. I know that we've been getting a lot of questions about, well, what about this diagnosis or this diagnosis? Again, these are examples, and we just have to make sure that whatever diagnosis needs that we're looking at, there really is a significant, there is risk of harm with it. Placing an individual in a room with no light and painful or damaging sound, those were included in the previous rule. Oops. You'll notice that there's been a change with electric shock. This rule excludes electroconvulsive therapy, ECT, as still, we can access that service for people as long as it's, being handled by a physician, clinical intervention. So that's a change in the rule. We never want to subject anyone to humiliating or derogatory treatment. No shaming. Squirting. You can't squirt anybody with substance. Back in the 90s, I used to work at a adult day program, and we had an individual who would masturbate in the back of the van, and that was what my coworker would do, would be to squirt him. It would stop it, but it never felt right that that's what we were doing, because there were so many other things that we could have done. So we've really come a long way. So we don't squirt people anymore.
Right. You know better, you do better, right?
You do. Yes. I can think of probably 5 different things we could have done right off the bat. But anyways, also using restrictive measures for punishment, retaliation, or convenience of providers, or a substitute for specialized services, that didn't change, but there used to be a teaching component to this sentence, and that was removed because our intermediate care facility folks with the CMS tags, there's a lot of language about teaching, so we did omit that for easier implementation for our ICFs. All right, so that's prohibitive measures, everybody. Just a few changes. Moving into types of restrictive measures. We started off with rights restrictions because we do see a lot of rights restrictions. So what are we talking about? Remember, it has to meet likelihood of legal sanction in order to do a rights restriction. Maybe somebody has pretty significant anger issues, and maybe they sometimes will lash out, and they have lots of coping strategies, but they're still figuring out how to use those in the heat of the moment when they get frustrated. And perhaps they lash out, and there's some physical aggression towards staff and others. And maybe that physical aggression is so intense that, it's caused people to have to get medical treatment. And it takes a while for the person to kind of calm down. So if if the team decides and the individual agrees that maybe, on a day when you're really angry and lashing out and physically aggressing towards people, maybe we're going to wait a little bit for you to kind of calm down and make sure that, that has passed. But that time frame that we're going to use, it goes into about 5 hours, just because the data and everything from the clinicians working with this person say that he really needs some time just to calm his body and his brain. And when I get upset, nobody limits when I can leave in my car. But for this person, even though he agreed to this, and the team feels it's in his best interest, it's still a rights restriction. So you can't do things to people with DD that you can't do to others. You can't restrict their personal freedoms as citizens of Ohio, and that's in the rule too. Heidi, do you have any examples of rights restrictions you'd like to bring up? I know this is your favorite section.
Yeah, sure. So you can implement a rights restriction, like Heather said, if there's a likelihood of legal sanction or if there's a risk of harm, right? So if maybe you have someone who their iPad is their very favorite item and they've broken it before when they're having a bad day. And so the restriction in the person's plan is if they're being physically aggressive, maybe, and they're also destroying some property. Maybe their iPad is put away because they love it so much. They've broken it a number of times and nobody wants them to break it again, right? Like that would be a rights restriction, not having access to their iPad. If you think about the folks, I remember one woman I met in a licensed waiver setting before. She was not even 5 foot tall, right? Probably 70 plus years old. And she would wear all of her necklaces when she went to her day program, right? Probably 50, 60 strings of beads. You have to think, right? Like, why is she doing that? Well, way back when she lived in a developmental center, she would come home and her things would be done. So in her mind, she likes to take them all with her. And so somebody trying to tell her that she can't, that would be a rights restriction, right? They would say you can only wear 2 strings of beads when you go to work. She wanted to wear every single one. So unless risk of harm or likelihood of legal sanction existed, you could not limit her strings of beads, right? People who load everything into their backpack, because they're worried it might not be there when they get home, Like you really have to think about if you're doing that, remember it's a restriction and why are you doing it? Because we can't do it unless there's a risk of harm or a likelihood of legal sanction.
Thanks, Heidi. We also wanted to bring to your attention that Lorain County Board of DD produced a number of 8 videos about rights, and they are excellent. They are posted on the behavior support webpage, and you guys, you have to check them out. If we had enough time, we would be playing one. I mean, they are fantastic. Check them out. They could really help you in terms, if you don't already have something available in your county or your facility, they could really help you reach people, the people we serve, maybe families. They're done very, very well. So wanted to do that plug. Also,
yeah, so
go ahead.
Sorry, if you're a provider agency, they're a great resource to train your staff, right? On annual training on the rights of individuals. Fabulous resource.
Yes, individuals were the actors and they're driving the message and you can't disagree with it. You can't argue with it. They're very well done. Very well done. Thank you, Lorraine DD. So the next type of restrictive measure we're going to talk about is manual restraint. So when you're putting your hands on people, this has to stop. Putting your hands on people has to stop immediately once the risk of harm has passed. I think the state of Ohio has done a really good job with making sure that we're taking our hands off people as soon as we possibly can. And that detail is listed out into the Ohio ISP. Manual restraints also includes disabling or holding wheelchair or other mobility devices so that the person is not able to, use their wheelchair or walk around. That's also a manual restraint. One thing we want to point out, though, oh, wait a minute, I'm getting too far ahead of myself. I do want to point it out, but just hold that thought. A manual restraint does not include a method that's routinely used during a medical procedure for patients without DD. So girls out there, you know, we use the stirrups when we go get exams. Maybe they have to hold your arm down a little bit so it's nice and still when you're giving a blood draw. I don't know, Heidi, have you ever been strapped to a board during a dental procedure? I haven't.
Have not, right. So that is a great example of something that is not routinely used, right?
Right.
Posy boards for dental procedures are not routinely used. So yeah, that's a perfect example.
For those of us who've been around for a while, we've seen that shift, and it's been very positive to see. Moving on to mechanical restraints. So this is when we're using a device to control someone's actions by restricting their movement or function. Again, the mechanical restraint needs to stop being used as soon as risk of harm has passed. Posy mitts, sometimes you'll get arm braces for those people who continue to try to self-injure themselves. Again, you know, those are mechanical restraints. Risk of harm has to be there, and you have to try lots of different things, which we're going to get into in a little bit. But mechanical restraint does not include seat belts that are found in an ordinary passenger vehicle or an age-appropriate child safety seat. So seat belts are not mechanical restraint. Now, if you put a buckle guard on it, because the person has shown that they do not have safe behavior while being transported and they try to open doors and jump out into freeways, and you have the data, you know, a buckle boss is a mechanical restraint, warranted given the fact that the person continues to try to jump out of cars despite our use of fidgets and music and all kinds of things. So that buckle boss definitely would be a mechanical restraint, but not the seatbelt by itself. Also, medically necessary devices such as wheelchairs or gait belts, it's all in how it's being used for that person. If you are slowing down a person's ability to move about in the room with a gait belt, that's a mechanical restraint. It may be warranted if it meets risk of harm, but if you're just using the gait belt to help them with mobility and to be able to walk safely, that's a support, not a mechanical restraint. Also, mechanical restraints could be a device that's routinely used during medical procedure for patients without DD. Heidi, do you have any examples of that?
I think that you may have covered them a little bit. I'm thinking about things that come across my desk.
I know, me
like
too. I'm sorry to put you on the spot.
Yeah, no. It's very much like when you said stirrups, right?
Yeah.
Like those would be a mechanical device and not necessarily manual, right? I can't think of any others off the top of my head, no.
I can't either. All right, we're going to move on. So another type of restrictive measure is timeout. We don't see timeout as much as we used to. So what is timeout? It's confining a person to a room or area and preventing the person from leaving the room or area. Again, timeout shall cease immediately once risk of harm has passed, or if the person in timeout engages in self-abuse, becomes incontinent, or shows other signs of illness. Timeout should stop then. Timeout is also limited to 30 minutes per incident and 1 hour in a 24-hour period. So you're going to have to track that if you're doing timeout. Timeout is not when the person takes a break and they're choosing to take a break for calming and they control when they resume their activities. That is not timeout. That is somebody just taking a break like I would take a break. But the difference between breaks and timeout is the person controls when they leave that area. If you're saying, well, I think we ought to wait a few more minutes, that's timeout. because you are preventing the person from resuming their activities. All right, chemical restraint. This is the biggest change in the rule, at least I feel it's the biggest change. So chemical restraint has changed significantly. We are developing job aids to help you through this. Heidi and I are neck deep in this along with external people, and we are trying our best to simplify this as much as possible for you. So chemical restraints, we are looking at medication for the purpose of causing general or non-specific blunt suppression of behavior. So that's what we're looking at for medication. We used to have prescriptions written for medications that would say Johnny needs to take Haldol, you know, for his aggression, and that used to be a chemical restraint unless the physician could identify the DSM-5 diagnosis associated with that aggression. With this rule change, we are no longer going to be questioning those orders. What we are looking for is blunt suppression with those medications. Very, very different. And I'm going to be really transparent and say that I've struggled with this. And I just keep going back to, well, what's the medication ordered for? And is that a DSM? That is not part of the thought process with this rule. What we are looking for is the medication that was prescribed, is it causing blunt suppression? So what is blunt suppression? Blunt suppression happens when the person has a significant change in their functioning, in their ability to complete activities of daily living. So it could be, I started this medication and it's impacting my ability. I used to run around the house constantly into everything, had lots of energy, and now I just sit. And even if you pulled out my favorite thing in the world, such as my iPad, I don't even care about it. I'm just sitting there and I'm not moving. Or maybe the person is independent going to the restroom, and now they barely can get up and go to the bathroom, and they forget what they're supposed to do when they're in the bathroom. That is the marked change that we are talking about with blunt suppression. Got a story for you. So, you know, I'm a cross-system regional liaison. I was called in to work with a team who was supporting a 16-year-old at the time. He had autism spectrum disorder and lots of mental health diagnoses. He was pretty active, and I poured through all of his documentation. He was a very active young guy and lots of energy, and sometimes would get dysregulated, and he would, you know, physically aggress toward people. So when we went in to see this youth, because the provider was really struggling to support them, he was just sitting there and he was kind of swaying, and he was not active at all, because all of the documentation I had seen, all of the incident reports, he was always on the move. You know, you had to really have your running shoes to keep up with him. Well, he was just sitting there, not even paying attention, you know, to anyone. And when he got up, he barely could walk. It took 2 staff to kind of support him. That's a marked difference. It did not match up with the plan. The next time I saw this youth at his next placement, he was busy and up running around. So when we say blunt suppression, we're talking about a marked change in the person's ability to function. This is going to jump out at you. Heidi, would you like to share anything?
Sure. So when you think about it, right, like the person is not functioning in the way that they normally do. And we will get to all of the questions when the PowerPoint is done. But so if normally they feed themselves and now they don't even care about eating and maybe can't feed themselves and need reminders, right, like that. So it's not just like, oh, this medication makes me a little sleepy or this, you know, that kind of thing. That is not what it is. It is much more intense. And Heather knows, and many of you know, I like to tell stories also.
We like your stories.
Right. When I think of blunt suppression, like there is a person that jumps into my head before anybody else, right? And this is, you know, probably at least 30 years ago. Back when I was a direct support professional, I was a one-on-one for a gentleman who was 19. It was in Pennsylvania, not Ohio. And he lived in what was referred to as a child development house. So we had group homes for children, right? At the time he was 19, he had grown up in this house, struggled significantly, went and lived at a developmental center in Pennsylvania for a while, and then came back. So came back to the same house, which now had many of the young men who were no longer children, right? And I was his one-on-one, which means, you know, I worked with him 5 days a week at home, and I went to work with him. He only went to work day program 3 days a week for like 3 hours. That was it. And wherever he went, I went, right? And, you know, he was always like, go, go, go. And when he was having a bad day, everybody was having a bad day, right? Like he had drugged me around that house by my ponytail on more than one occasion, right? And people were like, oh, why'd you have a ponytail? Well, he'd also, you know, wrapped his hands before, and the ponytail tended to be easier to get a release from. You know, he had done that one time in a CPI hold. He had bitten me on the inside of my thigh. Like his behaviors were so intense. You know, the staircase didn't have spindles anymore. It had plywood. Like his behaviors were super, super intense. And, you know, then after he went and saw the psychiatrist and we talked about this, he would walk around the house shuffling his feet, right? Drooling. He is what pops into my head when I think of blunt suppression. I think about him shuffling around the house, right? I kind of had our own personal behavior support program. At the time, he had a real one, but it didn't always work. But we had this thing like my mother owned her own beauty salon, and we would go get his hair cut 3 times a week. Yep. Like he loved to go to the beauty salon. Like we got to be good if we're going to go to the beauty salon. There's a lot of old ladies there, you know, whatever worked. That's what I tried. And we would go and my mother would snip, snip, snip around his ear, right? Like that was it. And when he was bluntly suppressed, he could care less about going to the beauty shop. When before that, he called my mom grandma, you know, we were about the same age. He called my mom grandma, and he could care less about going to see grandma, right? Like he was absolutely bluntly suppressed. Like poor guy. But he's who I think of, right? He wasn't just a little sleepy from his medications. He clearly could not function, like didn't care about anything. Yeah. Thank you, Heather.
No, thank you. Great story. So there was a change also regarding chemical restraint, medications for treating sexual offending behavior. In the previous rule, just to give the history, at one point we did classify medications for treating sexual offending behavior because, you know, as chemical restraints, such as Depo-Provera, that's for males, that's a pretty common one. So, and then there was a time period because those diagnoses, frauderism, you know, those are DSM, DODD did not consider those medications chemical restraints. I don't think we felt very good about that. So with this rule, they are definitely chemical restraints. So anytime you have a medication for treating sexual offending behavior, it is a chemical restraint. Some counties, some programs were, you know, they were still kind of running them through HRC, but now it is definitely required. Some other new language around chemical restraints. Chemical restraints can be utilized when there's risk of harm or a precisely defined pattern of behavior that is likely to result in risk of harm. In the chemical restraint webinar, Dr. Rick Cirillo talks about, you know, if you have a person, every time they become dysregulated, they go through a pattern of behaviors, such as maybe they have some scripts that they start talking about, like calling the police, someone's going to get hurt. These are just examples. You are able to use chemical restraints when you have that precisely defined pattern of behavior. Chemical restraint, this did not change the 4th bullet. This did not change in this rule. So chemical restraint does not include medication that's routinely prescribed for medical procedures for patients without developmental disabilities. The one that we always talk about is Ativan before dental services. That's pretty routine. If you're not sure if a medication that's being ordered for the individual you're supporting, if it's something that's routine for people without DD, go back to the prescriber. Go to the physician and see if this is something that is prescribed typically for people. A lot on chemical restraints. Next slide. So we put this slide in because the facilitators, they're like, whoa, that's pretty heavy. We need a few more words. So we just put some up here. You know, it's really important when you're looking at chemical restraint. This rule is not intended to interfere at all with the relationship between the doctor and patient. So we're not questioning doctors. We are just sharing information about how people are responding to medications, and we'll get into that in the next slide. Again, you know, that relationship between the prescriber and physician, it's so critical. And I know that people have been a little concerned about the changes with chemical restraint and that they are questioning physicians. That is not the spirit that you want to take with implementing this rule. It's more about just reporting how someone is responding to medications. You're advocating for the person so that they can live their best life, and taking that information back to the physician to see what could be done. And I put in the bullet too, no more consideration of DSM diagnosis. So if you see somebody prescribed Haldol for aggression, we're not going to dive into that and ask a lot of questions. But what we are going to ask about is, how does that person, you know, well, you're just going to, is that person being bluntly suppressed by that medication? And it's going to jump out at you. Heidi, anything else?
No, I think the next slide will talk a little more about it.
All right. So chemical restraint or not. So if when somebody's prescribed a medication and, you know, if nobody expected, you know, the person to be bluntly suppressed, but you find that the person, there's a significant change and they're not able to perform some of their daily activities that they used to be able to perform. This part in the rule, it's section E, you do need to reconsider that medication. So whoever sees the marked change, it could be a DSP, it could be, you know, the bus driver, it could be, you know, a parent, a family member, but just, so what you would do is the first time, you know, when you're not sure, you would report that to your SSA or your Q. And that person, the SSA or the Q, is responsible to notify the prescriber and team, making them aware that, you know, this person, their functioning abilities have changed significantly with this medication. Now, the rule does allow, many of you know this already, but, you know, sometimes when we try new medications, especially psychotropic medications, and many of our folks, you know, do use those, it takes time. So the rule does allow for 30 days. For the person to get adjusted to the medication. So if you see someone with a marked significant change in their ability to function, but you're still like in the first week of starting that medication, you want to give it until 30 days perhaps, because they might level out and they might, you know, they might resume their former functioning. So that was just a little side note. So after the SSA notifies the prescriber, you know, the prescriber may adjust the medication. Or you may change the time that you give the medication, because that might, you know, if you give it at night, they may be able to function okay in the morning. And then if the medication is not adjusted, the team just needs to meet to consider what actions are necessary. Heidi, do you want to add some?
No, I think you're good. I think you covered it.
All right.
I saw some questions that we'll be able to dig into a little bit deeper.
Oh, I can't wait. I can't wait, because that's where the learning really starts. All right. Framework of this rule. I talked about this a little bit earlier. So this rule, along with the previous rule, states that people have the same rights and personal freedoms as other Ohioans without DD. I find it personally sad that we have to list this out in our rule, but we do, and we'll just keep forging ahead. But So that stayed in the rule. You're going to notice that the language in the rule, content-wise, it didn't really change the spirit. However, the state of Ohio, we've really dug into trauma-informed care, and we've transitioned over to trauma-responsive practices. So you're going to see updated language, and I'll make sure I point that out. But it's very exciting just to see how we have evolved and how we are supporting people. Can we do better? Absolutely, we can do better, and we will continue to do better. So restrictive measures are used only when necessary to keep people safe, and we've covered that. Also, restrictive measures are temporary in nature. That didn't change. So as soon as we implement, the restrictive measure, we're trying to figure out ways that we don't have to use it any longer. And sometimes that takes time. Effort in enhancing a person's quality of life by really understanding and respecting their needs, and making sure that we're expanding opportunities for them to communicate and really have choice and control over their life. So, making sure that we are listening to people and being with them instead of shaming and judging maybe some choices that they're making that may not be the healthiest. Maybe, as humans, we just want to be heard, right? And that's when healing starts. So if we can just kind of shift how we're supporting people and really listening to them and understanding where they've been, what happened, and even if we don't know the whys, we can kind of, with trauma responsive work, you can see how we can respond to their emotions right now and respond to those needs, and just to build those new neural pathways for healing. I get really excited about this because it's so exciting to see people grow, and awesome. So service and supports are based on the person. Some things that changed were adjusting physical or social environment. Whoops. Sorry. Adjusting schedules. I am a morning person, but I have a family member who hates mornings. Oh my gosh. And it's a struggle. It is a struggle. And I swear, if he could just go a little bit later, things would be just happy in his world. So, looking at schedules, maybe the people spend a lot of time with their housemates, and maybe that's not a good thing. How can we adjust their schedules, maybe other programs or anything, just so they can get a break? It can really make a difference. Establishing trusting relationships, back to that trauma responsive. Trusting relationships, safe, positive relationships. It really helps people feel heard, feel safe, and it allows them to thrive. Heidi, do you have anything you want to add?
No, I think so many of these items get it really like, how does the person want their life to look, right? And
Yeah.
making sure that that happens in any way that we can. Like, I have another story. It's not my story. It's one of my teammates' stories. She was telling me one day she had worked at a place where the CEO was very much in charge of everything and what people could do and couldn't do. And there were GPS on all the vehicles, there's cameras in all the houses, all of that. And nobody should do anything that's inappropriate, right? Especially related to sexual kind of things, which often, come up. So this gentleman, he had a developmental disability. He was also deaf, but he communicated very well through other means. And he was really interested in young ladies and, strip clubs, right? But he wasn't allowed to go to the strip club because nobody at that agency was allowed to do such a thing, right? So one night they got a phone call. So since he wasn't allowed, he had borrowed the scooter of one of his housemates and drove it down to the strip club, about 2 miles, right? Like, that's what he did. He did that because nobody would let him live his life the way that he wanted to. People were power over him instead of power with, right? Instead of lifting him up and helping him make decisions. And he, instead felt the need to borrow somebody's electric scooter and ride it to the strip clubs. Like, really? Why are we doing that? Why are we doing that to people, right? So that was somebody else's story. My story, people who have a big fridge, but then have a little fridge that's locked up. The big fridge is locked. They have a little fridge with daily food, right? They agree to it. The problem is that you then see them panhandling on the corner, right? Like, why? Like, why are we doing things like that? So really thinking about the person's life, why they're doing the things that they're doing, and helping them make good choices, but also be independent, you know, without putting unnecessary restrictions in place that lead to other not the best behavior.
Great examples, Heidi. Thank you so much. So we've been talking about trauma-informed care perspective, and this is the foundation of this rule. You know, restrictive measures have to be designed in a manner that promotes healing, recovery, resilience, powering with people instead of powering over people. You know, strategies have to be developed in accordance with person-centered planning. Teams have to consider the why. And I have to say, State of Ohio, I'm pretty impressed with the work you've been doing. And if trauma-informed care is new for you, please know that you have an awesome network in Ohio to help you get up to speed. And you're going to hear a lot of just trauma, you know, building resilience, trauma responsive perspectives in our question and answers, or ask a friend, as Justin Madison says. So this is just a quick down and dirty process of restrictive measures. This is it, folks. You start with the assessment that has to be completed within 12 months that shows the risk of harm. And that is completed by somebody who meets the requirements. We'll get into that in a minute. Strategies are developed by the person who meets the requirements. Informed consent. And then you go to the Human Rights Committee for approval. And then you complete the restrictive measure notification in DODD's application. You train your staff, you implement, gather information from all the implementation, and then you do team reviews every 90 days. So this is the process. Just a nice visual. We're going to have more job aids for this too. We have
in this order, right, Heather? In
Yes.
this order. Yes,
in this order. Thank you, Heidi. So who can conduct assessments and restrictive measures? This didn't change. I think we eliminated BCBAs from the language, but the rest is the same. So you have to have a license with the Board of Psychology, Medical Board, or counselor, social worker, marriage, family therapist. You also have to hold a bachelor's or graduate level degree and have at least 3 years of experience developing or implementing restrictive measures.
Right, so that was the last one. So it's any of those first ones or this one, right? So I feel like most people in the majority of the people in our system fall under this qualification.
Yep, I agree with you on that for sure. Moving into assessment, we talked about how, you know, the plan has to be developed based on the assessed need. You know, this could be, you know, sometimes there are risk assessments for people with, you know, sexual offending behaviors or, you know, fire starting. You know, if you, in that 12-month period after you've identified risk of harm and restrictive measures, if there are incident reports that show that there's a continued need for this level of support and the risk of harm is still there, you know, you don't have to update that risk assessment. You can use the information from your incident reports. You can use clinical notes from maybe they're getting counseling and, you know, the counselor, you know, those sessions are clearly showing that, yeah, we still have risk of harm here. The assessment also has to it clearly has to describe the risk of harm or likelihood of legal sanction. Or it could also include the person's precisely defined pattern of behavior, you know, when you're considering chemical restraints that we went over earlier. Assessment has to describe when the behavior is likely to occur. You know, all the factors that can be contributing to the behavior should be explored and included in the plan. Heidi, is there anything you want to add to any of those points?
No, we're good.
Yeah. I'm just so excited. I want to get to the questions because I know that it's probably the chat is probably blowing up. I'm glad I can't see it. Into planning. So prior to the implementation of restrictive measures, we're going to develop the person-centered plan. It's one plan or Ohio ISP. We have no separate behavior support plans or behavior support plans inserted in the plan. This was in the previous rule, this was definitely an area that we struggled with. I know that Heidi did many trainings on how to interweave restrictive measures into plans. So I feel like we have evolved and we're doing much better with that. But if you're new and you're not sure, please reach out, please. There is no reason for you to struggle when we have so many rich, robust resources in Ohio. Your colleagues really, really do their best to help you. And you also have to ensure that this is the least restrictive option. It also has, the planning has to specify the steps that will ensure safety of the person and others. So, step by step. Here's the court-ordered information. So this has to, if you have a person that you're supporting that has court-ordered community controls, sex offender registration, drug testing, that information has to be in the plan. Also outlining necessary coordination with other entities, courts, prisons, hospitals. Many of you are already doing this work beautifully, but the rule just calls it out to make sure that we're all adding this information into plans. Team process. So when teams are thinking about restrictive measures, this should really be a tough decision for all team members, including the person. And doing this work and watching the questions and the team struggle to support people, I do believe that teams are doing a great job in Ohio considering restrictive measures as a last resort. And the person has the right to refuse too. So if they refuse, we just have to make sure that we're presenting alternatives. And I know that sometimes that can be very challenging, very challenging. You are never alone. Bring your scenario to a workshop like this. We won't be doing trainings like this all the time. We'll just have, questions and answers. So, bring it to a workshop, reach out to me, reach out to Heidi. We are here to help you. And alternatives, in finding those alternatives, you really have to find options that are important to the person, making sure that they value whatever that we are coming up with and promoting resilience. And I know that that can be very, very challenging, but we're all in this together and we will figure it out. So guardian imposed restrictions, this comes up sometimes. Sometimes guardians or families want the teams or the provider to take action that isn't really in line with the rule. Maybe it doesn't meet risk of harm, but and that presents a problem. So we just want to say that nothing prevents a guardian from making a request. And, SSAs or Qs, they really need to be encouraged to let the guardians know when those requests fall outside of the rule. Now, in doing so, it's very important that that relationship between that SSA or that Q and that family member, we want to do everything we can to preserve that. And sometimes these conversations can really disrupt that relationship. Heidi and I've been doing this work for a long time, and guardians, sometimes, they're making these requests out of fear. And, fear doesn't go away, right? You've got to work that relationship. You've got to be able to help that guardian understand that we want the best thing for, the individual as well. So making sure that supervisors and administrators are available to support that SSA in those really tough conversations. And just figuring it out. You've really got to build that relationship and just figure out a happy medium. You really do. And sometimes that can be very challenging. Please do not think that I am minimizing that work in any way, shape, or form. Heidi, do you have anything you want to add?
No, I think you've covered it well. Thank you, Heather.
Doctor's orders and recommendations. So sometimes we might see doctor's orders for restrictive measures. Even though the physician is a very important member, there's still a team. And if decisions are being made by one person on the team, it really isn't person-centered. So we have to make sure that risk of harm or likelihood of legal sanction would still be met with, with physicians' recommendations. And sometimes, maybe the physician isn't aware that the person has no intention of even trying what they're saying. So what else can we do to support this person? Human Rights Committee, we're wrapping up, guys, getting to the end here. There were some changes in the Human Rights Committee section of the rule. So a Human Rights Committee and specially constituted review committee, which is in the intermediate care facilities, those two committees they serve the same purpose per the DODD rule. So human rights committees have to be balanced. A nice balanced number of people who are receiving services or family members, along with DD professionals. It has to be balanced. We want to make sure that we are getting everybody's input with restrictive measures, because these should be really tough choices. Everything that happens in the Human Rights Committee is confidential. Nothing changed with that. And members have initial and annual training requirements. And again, as Heidi said, we have a new updated training for you all, and it's almost ready, but not quite yet. And human rights committees can approve restrictive measures for up to 12 months. They also can approve them for less time too. So here are the changes for Human Rights Committee. The rule added emergency requests or routine requests. Many of you out in the field, I think a very high percentage of county boards and intermediate care facilities already had an emergency request process. So this rule just formalizes that and makes it a requirement. So if you are one of the counties or intermediate care facilities that maybe doesn't have this process, please reach out, because we have a lot of examples that I'm sure we could get for you. With emergency request, informed consent is required. There's a lot less information that's necessary, and you need a quorum for approval.
Heather, I think it's important to add emergency requests are for those things that come through that need an immediate approval. It is not, and the language, part of the addition of the language to the rule is so that it is not utilized as a, oops, we forgot to go to HRC for a routine request.
Thank you for adding that, Heidi. Also with routine requests, there's a change that you have to give notice to the person or the guardian 72 hours prior to the HRC meeting. This is a new requirement. We have had instances where, people they want to present to the Human Rights Committee. They want to share information that maybe they don't think the committee understands. And this has opened up that possibility for families. We were getting a lot of feedback that families didn't feel like they had a voice through this process. So there was language added for, notice to the individual or guardian prior to the meeting, but that doesn't mean that they have to attend. It's only if they want to attend. So far, we're not thinking that this is going, that you're going to have lots of guardians and lots of individuals wanting to attend Human Rights Committee meetings. Another change, this has always been required, but Human Rights Committee's determination is shared with the guardian or person after the meeting, and then the guardian or the person has 14 days to share additional information with the Q or the SSA if that restrictive measure is rejected. So if the Human Rights Committee, say for instance, says we are not approving this restrictive measures because there is not enough data, there's no data in the last 12 months to continue this restrictive measure, that information would be shared with the guardian, and maybe the guardian or the person has additional information that they want to share with HRC that could maybe change their mind about whether it's approved or rejected. So they would share that information, and then HRC has 14 days to respond to the guardian or the person. So we're anticipating you'll have some questions about that, so we'll get to them here in a little bit. But those were some changes. And then we go on to 90-day team reviews. COVID really helped us realize that we don't have to be in person to get some work done. So lots of creative ways to get the 90-day reviews done. with this rule, there's more of a focus on the person and getting their input, how they feel it's going, how is their life going, how is the use of the restrictive measures going, are there things that could be improved, but really going back to that person who's receiving services with the restrictive measures, making sure, getting their input. This rule really emphasizes that, and that's a really good thing. I'm not going to read all these to you. Here we go. I got a little ahead of myself, just making sure that the person's overall satisfaction is happening. And if not, what can we do to help that person better? There was a change in the 90-day reviews for manual restraints. The 90-day review shall include prospective at least one DSP involved in the restraint during the last 90 days. We have received some questions on this, and it is just one DSP. Even if you implemented the restraint, 15 times with 5 different staff, you only have to get the perspective of one of those staff. It's really important that we get down to that level. Doing restraints, it's not easy work. So just, is there anything that we could do differently to avoid restraint and getting their input? Annual analysis. This is, we're going to have a lot of training on this. Lindsay Terry Stein is, with the RMN application, she's always got lots of great information for us. And I know that she's scheduled for early next year to do a presentation on annual analysis. So you're pulling information, you're presenting to HRC by March 15th. And the data must include, all of these bullets. And again, whoops, I'm sorry. We're gonna really dive deep into annual analysis early next year. Heidi, anything you want to add?
No, I do think it's important to note that all of this information you will be able to pull from RMN, and then you'll just kind of dig deeper into it, taking a look at one of the 2 items that the in-depth review requires.
Yeah, it's always an exciting time of the year when we're able to get RMN to help us with these reports. It's been a big improvement. All right. So the next slides are only for intermediate care facilities. So we just want to point out that the DODD behavior support rule and the CMS Ohio Department of Health tags, it all lines up. In fact, we meet, well, that's a slide later, but we meet with ODH on a regular basis, and this rule actually aligns even more closely with their requirements. So if you're working in an ICF and you're like, oh my gosh, does this rule match up? Yes, it does. All these tags, all of this information, positive behavior, reinforcement positive behaviors, restrictive techniques only when there's severity of behaviors. And another slide, hierarchy of interventions, positive before non-aversive, positive before aversive. You have to have informed consent and written unless emergency, and they have prohibited measures as well. And then there is a part in the CMS tags, psychotropic medications for diagnoses require monitoring for certification. So this lives outside the DODD rules. This still falls in line. You're still going to have to do this for your certification with the Ohio Department of Health. We've had several ICFs tell us that this is a very important slide for us to point out. So, and the CFA is captured in the Ohio ISP as well. All right, and we are partnering, as I said, with ODH. If you bump into any inconsistencies, please share this information with Heidi or me, and we will do our best to help you. Anything you want to add to that, Heidi?
No, I think, and that behavior.support at dodd.ohio.gov, right?
Yes.
If you can't get a hold of one of us, shoot an email there, and we will make sure to get back with you. I said no, but that might be a little bit of a lie. So when you think about, reviewers, surveyors for ODH, reviewers for DODD, all the county board and COG reviewers, we have requirements, we have interpretations, We have, meetings amongst different agencies and offices. But everybody who is completing a review is an individual person, right? So sometimes somebody may have missed a memo, missed a meeting, or making their own interpretation. And if you don't believe that it is accurate, like Heather said, get back with us. And something I like to ask, just because somebody asks questions doesn't mean that they think you're wrong, right? So we think about, was there a citation? If there wasn't a citation, then most likely you convinced them that this is the interpretation and this is how we met it. So just a surveyor or a reviewer asking questions is not necessarily a bad thing. They're just trying to get a better understanding.
All right. Thank you so much, Heidi. All right. This is our favorite slide because this holds true even in 2022 with the new rule. There are no blanket answers. One little twist in details can send you in a different direction. So please reach out. Do not struggle alone. We are here to help. Here's our contact information. And with that, we are finished.